Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. We are at the 122nd episode, and today the podcast is also brought to you by Keck Medicine of USC, over 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, Los Angeles, California. So my topic today stems from just some discussions that I've been having with some of my clients and potential clients on workflows and revenue cycle management protocols. And I kind of wanted to bring everyone up to date. I think sometimes we get stuck doing what we've always known to work. And so making a change or updating at times is tough to do. And sometimes it's even a tougher sell to the physician and administrators because, it's always the old adage, if it's not broke, don't fix it. But to compete in medicine today, you have to be up to date and you need to be competitive, not only in your surgeries and your procedures, but also in your collection processes, in your revenue cycle management process. So I'm going to discuss collecting patient money and also certain levels of appeal with Medicare because some of the confusion out there is causing some errors and some slowing in what you're doing as far as your processes. So we just want to make sure that you're aware that there are some issues when it comes to how to appeal on a Medicare perspective or Medicare claim. And then also just making sure that you're updated and really understand some of the processes that have changed over the years. Perfect example. Remember insurance claims? Now this is going to date me and some of you, I'm sure. So remember our insurance claims used to be on what we called HCFA, old paper forms, and they were sent snail mail. So it was usually 3 to 5 days to get the packet out the door, plus then another 4 to 10 days for the payers to receive it. And it went to different areas of the actual payer. Now what happens? We submit electronically and usually within 48 hours of the service being performed. Patient statements. So those were printed in-house and sent by snail mail. Again, we hand stamped and then also hand enveloped each one. And 2 to 4 days to get them out the door, plus again 4 to 6 days for the patients to receive them. But now we again can do electronic submission and they're sent to the patients within 24 hours, plus 2 to 4 days for patients to receive possibly. But now we can have them pay through portals and online, and I'm going to talk to you a little bit more about that. And then we get into patient payments. And when we talk about patient payments, most common method of payment back in the day was a cash or a check, and 4 to 6 days to get payments in the mail, plus 1 to 3 days to post the account. We also did payment posting by hand, and a lot of times now that's done electronically or auto post. And now its most common method of payment is really a credit card. You can process it instantly, plus 1 to 2 days to post the account. Also, you've got some things where when they're getting posted, it gets paid earlier because there's now options for patients. And then insurance patients, usually they were sent by snail mail, posted manually. I remember going to a lockbox when I had a billing company years ago, and we basically grabbed all of our checks and posted them manually. But now major plans, they pay electronically. Most again are auto posted. And so the average AR used to be anywhere from 45 to 75 days. Now it should be 25 to 40 days at tops. But I'm still seeing some of these, some of these old habits die hard. And I'm still seeing ARs that are still 65 days. And I still see some practices, believe it or not, are sending insurance claims by paper. I had one, it was actually a physician practice that I went to, just like a walk-in clinic, urgent care. And they actually sent my claim by paper. But how did I know that? Because they sent the window envelope with my address on it instead of the insurance company address of where it should have gone. And I was so annoyed that I'm like, oh my gosh. So I walked it into their practice. I said, yeah, this doesn't go to me. This goes to the insurance company. And why aren't you sending it electronically? I have Anthem Blue Cross. So you should be set up with them. And so they were very embarrassed that that's how something kind of got back to the patient. But those are the types of things that I see quite a bit still ongoing. And we want to make sure that we are not falling into that trap. Now, when we talk about patient payments, we need to really be kept updated. And I can't stress enough that when you're evaluating your accounts receivables and your collections, I really believe that you should start keeping a credit card on file for patients and then have them sign a document noting that you can charge the balance to their cards if they don't pay it. And you have to get their information on a credit card authorization form. So having that credit card on file, it really removes the obstacle to receiving payment. So patients know it's on file. It adds a layer of patient responsibility and financial responsibility, and they can't just ignore the balance, which some patients have traditionally liked to do. So make sure that your patients sign a pre-authorization form. And what that includes, it has to have the patient's full name, and it's the name on their card, the type of credit card, the billing address tied to the card and phone number, the credit card number, obviously, the CVC on the back. Okay, so that's where they call it the ID number. So if it is a Visa or MasterCard or Discover, on the back it's a 3-digit code. If it's an American Express, it's a 4-digit code in the top right-hand corner. And then obviously the expiration date, and then make sure that you have staff that are also updating those. The form can also allow the patient to elect to be billed by mail instead, paper statement, with the stipulation that if payment is not received within the net 15-day due date, and it should be net 15 days. Why does anybody get to keep your money for 30 days? Again, you say the credit card on file will be charged. And be sure to use, HIPAA compliant emails and online payment portals. And just some additional best practices when keeping credit cards on file. Any offices that I've set up with this, they said their collections have gone up by almost 12%. I've seen that 10 to 15%, so an average of 12%. But first of all, keep it simple and direct to avoid offending your patients. Put it in your financial policy in bold print and explain it as a service to help avoid billing hassles when the remaining balance comes due. Inform patients of account balances after the insurance responds, because you don't want to surprise them with charges. The hospitals right now are in legal issues with something called surprise balance billing. And they're having to forgive some of those balances if it's been at least a year. And we don't want to get into that. So let them know that you would like to bill for the balance to end to the card within 48 hours, and treat it as a courtesy to give them time to provide another form of payment. But 48 hours should be it. And then scan the credit card information into your EHR and destroy any hard copies for an added layer of security. Call your merchant services company, the one that gives you the card readers, to ask about features that protect the stored information. So this not only streamlines the process, but also transfers the security responsibility. But be firm and consistent with your policy. You're going to have some opposition from patients, but this shouldn't be an option. Be willing to address it on a case-by-case basis. Some patients aren't certain of their financial future and stability and simply will not comply with the policy, but you need to make sure you've got an alternative, such as having them sign a financial responsibility form that promises to pay within 15 days of receiving the bill, or again, they're going to be charged or possibly discharged. But you need to be very clear about that. That should be a policy in your office. Everyone nowadays has some form of credit card payment or debit payment or something, and they need to know up front and make sure that your financial staff reiterate this issue when they have a procedure or something that reaches a threshold that and could be possibly denied, or they're going to have an out of pocket. So for example, if you're a gastro office and the patient's coming in for a screening and they just assume that this is going to be no out of pocket, make sure somebody is sitting down with them and talking to them that if it is a true screening and they don't find anything, then you're sent home, then yes, you won't have an out of pocket for the physician side of things. You'll still have something for the facility and labs, etc. But for the physician, your deductible and copay would be waived. However, if a polyp is found and removed, most payers will still waive their deductible, but your 20% will still be your responsibility. Patients need to know that. If you do an EGD at the same time as a screening colonoscopy, it changes it to out of pocket for the patient as a diagnostic. So now they would have to pay their 20% plus their deductible or whatever their out of share of cost is. So make sure the patients understand what their out of pocket is when there is a procedure or a test or something that is above and beyond an office visit as well. Otherwise, you're just going to run into trouble. But you absolutely should have, every patient needs to have a credit card on file for anything that they can be balance billed for. It should not be an option. And I get very frustrated with practices that allow patients to dictate their financial policy. So don't let them do that. That is something that they're going to have to participate in. So make sure that that's there. Okay, so my coding question actually is going to fall into what I was mentioning before on levels of appeals. So I got a coding question from one of my Colorado members of my Coding Corner, and it said, Terry, I submitted a claim to my region's Medicare administrative contractor. That's the MAC carrier for Part B patients. So, but Medicare denied the claim, and I want to appeal the decision. So what are the levels of the appeals for Medicare, and what are my options? Okay, so first of all, there are 5 levels of appeals for Medicare. But before you can request an appeal, you must have a processed claim by Medicare. So it either has to be fully or partially denied. They have to at least have it allowed. So it has to be in their system. So, and also notice that there's certain things as I go through some of I go through all the appeals, that there's some dollar amounts that have to qualify to submit a certain appeal. So a level 1 appeal, that's a redetermination. It goes with a form and it goes to your MAC carrier. So that's who you build your medical services to. So the same place is where you're going to set an appeal. Now, when you get to level 1, for a redetermination level 1 appeal to be considered complete, the provider must include all of the following information. So the beneficiary's name, so that's who has the Medicare card, the Medicare beneficiary number, and remember it's now a different number than their social and with a letter after. Now it's an MBI number, which is their Medicare beneficiary ID number. And then you also need the requested service, the date of service, and the name of this and signature of the requesting individual. And if all of these elements are not included with your initial level 1 appeal, your MAC carrier will dismiss the case as incomplete. And it's very hard to get somebody else to look at it. Now, level 2 reconsideration, which goes through the qualified independent contractor, they call it a QIC. Requests for level 2 appeals can only be made in writing, and this is now going to somebody who didn't take part in the level 1 appeal. So the qualified independent contractor, when you get the redetermination notice you got in level 1, and let's say you didn't like what the outcome was, it has directions for you to file a request for reconsideration. So it'll give you a form or tell you to fill the form out. And you can find it also as it's called a Medicare reconsideration request form on the CMS website, and then Medicare.gov, and just put /claims -appeals, and you'll find it. And then you submit a written request to the QIC, and it has to include the name and Medicare number, the specific item or service for which you're requesting a reconsideration, and the specific dates of service. And then the name of the company that made the redetermination, so the company that handles the claim for Medicare, and then an explanation of why you disagree with the redetermination decision. And if you've been appointed a representative, include the name of your representative. It's usually on your letter. And then no matter how you choose to request reconsideration, the request should clearly explain, again, why you disagree with the redetermination from the decision from the level 1 service, and send a copy of that redetermination notice. Remember, you have to make sure that you have a good argument, because the QIC won't make a decision without a good argument that there was a violation of a regulation, or there was something that wasn't considered in the first order of appeal, or the first rung of appeal. And then in most cases, the QIC will send you a response called a Medicare reconsideration notice about 60 days after they get your appeal request. And if the QIC doesn't issue a timely decision, you can ask them to move your case to the next level of appeal. So the next level of appeal would be an administrative law judge, and that has to be made in writing as well. But your claim also has to be worth at least $160 to file the level 3 appeal. And then let's say you're still moving up and you haven't got your outcome you're looking for. Now you have a level 4 appeal, and Medicare claims Appeals Council Department Appeals Board, that's a DAB. Their claims for a level 4 appeal must also be worth at least $160. And then your final place would be a U.S. Federal District Court, and you probably want to consult a Medicare attorney as well. But claims for a level 5 appeal must be worth at least $1,630. So there are some thresholds when it comes to money and claim value before you can move past a level 2. So just know there's some options there, but have good information when it comes to making sure that you are asking for an appeal that is necessary, that is valid. And it's not just because, the doctor says, well, I want to get paid, but, we all want to get paid, but that doesn't necessarily mean that you should get paid based on the claim and how you reported it. So it's really important to make sure you're reviewing the claim, understanding the payment situation before you just say, okay, let's go ahead and take it up the ladder. Otherwise, it would be a problem. One of the things I always tell physicians when they ask me, well, why can't I do that? I said, well, first of all, if you bill something that I'm giving you advice that it's not appropriate to bill, and I can't appeal it, or I can't in good faith support it if it should be questioned, then of course I'm going to tell you that you shouldn't be billing for it, because every claim that I look at, can I appeal that successfully? And that's what you want to ask yourself if you're going to submit anything to a payer. Could you support it and appeal it successfully? I'm having a huge issue right now with several practices not understanding the Incident to guidelines. And I brought this up quite a bit. We even talked about it on a podcast a few weeks back. And you're going to get in trouble if you don't understand those services. And when you go to appeal, you better make sure that you have your ducks in a row. Was there a physician in clinic? Was it by a qualified healthcare, professional, mid-level provider? Was it for E&M services that are established patients, not new patients, and so forth? Another situation, I'll deal with cardiology for a second. If you have a heart cath and an intervention, was the heart cath diagnostic at the same time as the intervention, which led to the intervention is my point? Or was it for setup? Did they just inject and get it, or set it up, get the patient set up with the injection into the coronary artery so then they could put in a stent? That's not billable as a heart cath in addition to the PCI. So if you get a denial, first of all, you shouldn't have billed it to begin with. But knowing your rules on that is going to be important. Another thing that comes up quite a bit, and I think this happens on wound care and debridements more than anything, and it's something called MUEs, Medicare Unlikely Edits. And I don't know if you know what that is, but Medicare has a file that says that, okay, this add-on code or this particular code, so let's say it's a debridement or it's wound care or it's removal of lesions or anything like that. MUEs means this is how many times I should see this code per encounter or per date of service. And for example, a 11047, which is above and beyond surface area of over 20 square feet, centimeters on lower back area, let's say, for a patient who's having debridement. Well, I had a physician that had 46 units. Well, they're only going to pay 4 units per day. And so what happens is if you put in more units of that, first of all, you're going to get a denial. But secondly, the claim is more likely to be kind of flagged for an appeal by the payer and by a review by the payer, I should say, and you couldn't even appeal it. So when I see some of those and I'm like, okay, you want this appealed. Well, we have MUEs saying this is not, likely. Now, are there occasions when maybe there's an exception to the rule? Yes, there's going to be that on occasion. But if I start to see a pattern where a doctor's trying to bypass something, that's going to be an issue. Know if you can bill for something that you can actually appeal. And another example that I had recently was there was a physician that is saying that he wants to do these overreads from x-rays that were done by another physician. He's saying, well, the patient's bringing them into my office, so now I'm overreading it. And I'm like, what are you doing? You can't do an overread on something if it's not a second opinion. Just because you're looking at it, that's part of your medical decision-making process to review the record. And so it was just interesting that they were trying to charge for this, and they're coming to me saying we're getting denials. And I wanted to say, okay, well, duh, you're going to get a denial if this is not something you can bill for. And so you have to know the rules on when you can bill for something and when you can't. And don't just throw it out there and hope it sticks to a wall. There's certain things that you can and can't bill for, and you need to know your rules. Another thing that comes up is, let's say, medical nutritional therapy. So you've got a dietitian in your office, and let's say you're a bariatric practice. And so you're having the patient see your dietitian, so you can teach them more beneficial ways, to choose their food and grocery shop and how they eat and behavioral patterns, things like that, because they're going to have bariatric surgery, let's say. Well, this can be a value-added service for your office, but it doesn't mean that you can bill an E&M service for it. Right now, medical nutritional therapy is only something that, for example, Medicare pays for a diabetic patient or for a patient that has chronic kidney disease. So you can't bill for services of a practitioner that isn't qualified to bill for E&M services. And I see this, oh my gosh, all the time. And then the payer comes back and says, I want to take some money away from you. And you don't want to have that conversation with the payer. And so when we talk about updating and practice checkups, and that's really what I was trying to kind of bring as my theme today, make sure that you are giving patients every option to pay their bill. Make sure that you're understanding who can bill for services and who you can include on your claims for services. Know when it's appropriate to send an appeal and follow up. One of the things I pride myself in my business is that I have a 99.3% track record with collection and appeals. Why? Because I know it's accurate, what you can submit. I'm very, very clear on being revenue cycle management current and appropriate. I want to make sure from the time that patient walks in the door to the time those services are ordered to the time the patient receives the services, they leave the office on a billing statement, and then we receive the money, that I know that was the appropriate thing they can have. It's a covered service, and we've crossed our T's and dotted our I's when it comes to waivers and understanding what the patient's out of pocket would be, etc. I'm absolutely positive that you want to be the same. You want to make sure that you're not spinning your wheels. You're not sitting there doing these appeals and trying to do things because that's how it's always been done. That's what you've done before. And so please try and be as updated as you can. I got a lot of good feedback from people last week when it came to the mistakes that are made on coding and billing. And I appreciate some of those comments that I did receive on that episode. I got a lot of good comments. I actually wanted to mention some people who did send me some great comments on that. And one was Rebecca. Good luck with your test. I know you'll do great. Laura, I appreciate your comments. Karen, it was so nice to meet you. I met a healthcare attorney, and she's been listening to the CodeCast, and we really appreciate some of her comments that she gave to the CodeCast. So just hearing some of the people really reach out and say, oh my gosh, finally, Fami, she's one that's been commenting on a lot of this for a while, and saying, you finally said something about people trying to use the nurse visit for everything. So thank you for that. So it's the same thing with just being updated. Know what you can do, know what you're allowed, and try to really educate people within your practice not to take it too far, because it could come back to bite you, and we don't want that to happen. So hopefully everybody is going to take some of this information and incorporate it into your workflows, incorporate it into, being a little bit more mindful of what you can and can't do in your protocols. And that way, when you start to do your appeals, when you start to get to different levels and you're starting to look at collections from a patient perspective, you'll be updated. Today's coding question was brought to you by Cadillac. Others talk about the road to success. We make cars for it. Cadillac. Make your way. Cadillac.com. And Netflix. Stranger Things. Want to make sure you're watching. Stranger Things has come out, and now they have up to season 6. So make sure you're looking at Netflix.com. So I wanted to end this week, my personal insight, with a brand new book that actually was released today, and it's called The Other Misses by Mary Kubica, Kubica. It's a murder mystery, and you know what? I only wanted to read a couple of pages and then pick it up later. It's what I like to do when I don't have football and there's no baseball started yet. But I couldn't put it down. I almost was late just coming into work, but it is amazing. So I'm halfway through it. It is intrigue, again, a murder mystery, and it makes me want to start a true crime podcast, which I'm actually writing right now. So I'm hooked. But Amazon and Kindle for Amazon have it. So check it out. Again, it is called The Other Misses by Mary Kubica. So hopefully you enjoy that. So everyone, on this Terry Tuesday, make it a great day and a great week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.